So this is a limb development tutorial presented by the SchrDbb. We reference Langman Medical Embryology by T.W. Sadler. So here we're going to start with, we're going to work with the limb embryology. So in limb embryology, we just visualize this diagram first, which shows the budding systems of the limb. So this is the development of the limb bud in the embryo. So this is a limb bud at the feedback. Here you can visualize the different somites at this level from 1 to this level. So and the somites are going to extend now into the limbs. Here you can visualize here the pharyngeal arches. Here you have also the pharyngeal arches which are going to derive from the somatomes. We have A at 5 weeks. The next one is going to be at 6 weeks, where you see the buds are going to be produced more, and then the last one is at 8 weeks here. So now here this is, you see that the limb is going to be comprised of both the endoderm and the ectoderm. So here you are going to have the ectodermal ridge here. So this is the ectodermal, the apical ectodermal ridge here, as you can see. So this is the ectoderm that you can visualize here, and the different on the longitudinal. This is the longitudinal section, and then this is the surface view. Now here you visualize that what this is schematic view section of the limb of the hand. So you need to know that as the limb grows, so normally in the hand you have a web space between the different fingers. Is it clear? Now in that web space, in order to prevent syndactyly, what's going to occur is that you are going to have this area between the web space, at the level of the web space there, is going to be an area of cell death. So cells are going to be dying there by apoptosis while the limb is going forward, basically, and then the bones are also differentiating. Now you can visualize here, and now this is for the lower limbs. Now for the lower limbs, you're going to have the different bones of the lower limbs, as the pelvis, the ilium, the ischium, the femur, the fibula, the tibia, the tarsal bone, the different metatarsal bones. So the tarsals, the different metatarsals and all that. You see, visualize this is still the web space, and this web space is going to be to die by apoptosis. Is going to be area of cell death in order to prevent that. Now this is still another diagram here. Now this is the last diagram. So the last diagram show how the bones are completely matured here. Now you see that in the formation of the bones also, you still have the formation of the endochondral formation of the bone system. So endochondral formation still start from the mesenchymal region. Then the mesenchymal region is going to differentiate to produce the cartilage, to produce the chondroblast. Now after the chondroblast, now the next thing is that we're going to have the mesenchymal cells aligning the cartilage, is clear. Now when you have the blood supply now to the cartilage, you are going to have a primary ossification area, and that primary ossification area, there is going to be proliferation of osteoblast cells, and when you have proliferation of osteoblast cells, it's going to result to bone mineralization, and bone mineralization is going to result to the formation of the bone tissue. Then later on, you're going to have the formation of secondary ossification centers by the supply of different blood vessels at the different apical regions. And then between the primary ossification center and secondary ossification center, there's going to be a plate of cartilage that is not going to be ossified, and that plate of cartilage that is not going to be ossified is going to be called the gold plate, which is also called the feces, basically. And then at the level of the feces, you're going to have you're going to have interstitial and appositional growth, such that is going to push the cartilage can easily grow and push themselves in their matrix, so that they can cause the lengthening of the bone, basically. Now still, this is the diagram showing the different somatomes and the somites. So with the somatomes and somites, you see that in the somatomes you can visualize the eye muscles, you can visualize the pharyngeal pouch. These are the pharyngeal arch here. So the first to the foot pharyngeal arch, which are supplied by different cranial nerve. The eye muscle is supplied by oculomotor nerve. This is going to be supplied by so the cranial, you have the pharyngeal pouch 1, 2, 3, and 4, which are supplied by different cranial nerve physically. And then these are going to the occipital myotones, which are supplying the neck muscles, which are supplying, and the muscle in the occipital region. And then these are the cervical and the thoracic myotones. So this diagram, we have already seen that in the formation of the muscular system cells. Now we need to know that what as the hand grows anteriorly and posteriorly, there is going to be attachment to a particular dermatome and a particular myotome, basically. But generally, the diagram which can be used in the formation of the dermatome and myotome is better seen from the posterior view. So posteriorly, we have C4, we have C5, we have C6, which come here and touches the dome. So it continues. You have C4, C5, C6 goes to the level of the dome. Then C7 comes, it takes the first and the second, it takes the, so this is the first digit, it takes the second and the third digit. And but this one is the first finger and the second finger, because there are 4 fingers on the hand and there are 5 digits on the hand. The thumb is not a finger anatomically, but the thumb is a digit anatomically. So this is the second and third digit going to be supplied by C7. Then C8 comes here, takes the third, the fourth, and the fifth digit, and then you can go there. Now, anteriorly, we see that was C6 come here. C7 has no part in the center. Is it clear? C7 only takes the finger at the level of the hands. Is it clear? And then C8 has an extension here. So C7 does not have an extension into the forearm and the arm. What have an extension in the forearm and the arm anteriorly are C5 and C1. Is it clear? So those are the points you have to know. But posteriorly, they are having their different layers. Anteriorly is slightly different. Now, this is the regulation of the limb patterning and the growth. So the regulation of the limb patterning and the growth occur by different biochemical processes regulated by the fibroblast growth factor 10. Basically, in order to have a specific enrollment, you see these are the different biochemical molecules involved. So the radical fringe molecules are involved here, the engrailed one molecules are involved here, and then the cell2 molecules are involved here. So in order to understand more of this limb patterning, you can visualize, you can put a pose and you visualize on different diagrams here, but I'm not going to speak about that. Now, the clinical correlation. So what are the clinical correlation? The first clinical correlation is going to be bone age. You need to know that there are different ways in order to visualize the age of a child. One, we are going to have the chronological age from the birth of the child. So is it clear? So if you want to know the age of somebody, you can ask from the chronological age. From chronological age, from birth, you count the age of the child. You can know that's the age of the child from birth till the day you are seeing the child. Now, the second thing is, how can you visualize again the age? You can visualize the age by clinical maturation, clinical features. Example, you can use the Turner classification in order to approximate the puberty age of the child. Is it clear? So you can use the Turner age, Turner maturation in order to visualize the puberty age of the child. Is it clear? So you use the breast lumps, or you use or both males and females, and then you use the pubic hair growth at the level of the pubis of both the males and females. And you can also use even the testicular size in you use breast in females and use the testicular size in males, and then you use the pubic hair growth. Is it clear? In the Turner classification, in order to slightly know the age of that child. You can also use the biochemical to visualize the age of patient. You may use also biochemical analysis to find the level of the hormones inside the child at the level of puberty. Is it clear? Now, but the two main things which are used in order to visualize the age of a patient are the chronological age and the bone age. So this is why bone age is very important. So radiologists can use the bone age, so this bones in order to visualize the age of a patient. Example, you can see the ossification of the sesamoid bone at the level of the thumb in order to visualize the age of a child. Is it clear? So that is where you have bone age. Bone age is very important. You can use the hand and the wrist or you can use the foot and all that. So in different patients. Now the limb defects. You have also another clinical correlation, which is limb defect. Now limb defect now can be divided generally into two. We have meromelia, which is a partial limb absence of the limb, and then amelia, which is a complete absence of a limb. Is it clear? Now meromelia can be divided into two. It can be divided into focomelia. Focomelia is when you have no long bones of the upper and the lower limb. You just have the hands are directly connected to the paraxial skeleton. Is it clear? While micromelia, you have all the long bones, but the upper limb are smaller than normal. One upper limb is smaller than normal. There's no symmetrical small limbs, because if you have symmetrical small limb, it's going to be considered a skeletal dysplasia, and in that case it may be hypochondroplasia or it may be an achondroplasia. But when you have a unilateral or one limb is small compared to the other, it's going to be called a micromelia, and it's a limb defect. Now the next one is going to be, so you need to know that what limb defects may be congenital abnormalities, and these are they may be hereditary, but there are certain cases, and most cases have been seen in case where you have exposure to thalidomide, which is a sleep pill and is an anti-nauseated pills. So that drug now has stopped to be used. So in this case, you can visualize here, this is amelia here. You can here visualize the hand here. At this level of this hand, you have a cleft. You have a cleft hand. I'm going to tell you more about that. And then here you can see here at this point here you have this diagram here. You have a focomelia, and a focomelia and micromelia are examples of meromelia, which is a partial absence of a limb. Is it clear? So on this hand here, you can visualize a focomelia at this level. Now, the next one here, you have to know the limb defect. Other limb defect, you can have brachydactyly, which are short and fat fingers. You have syndactyly, which are fused finger. You have polydactyly. Polydactyly is increased number of the digits. You have ectrodactyly, which is loss of certain digits, such as the thumb example. So now the cleft hand and the cleft foot, usually it is an abnormal cleft between the second and the fourth metacarpal. So we have an abnormal cleft between the metacarpal bone. Usually it is between the second and the fourth metacarpal bone, with the absence of the third metacarpal bone. Is it clear? And the third metacarpal digit. So this is due to different mutations. Example, you have the Hox gene mutation, and with the Hox gene mutation, you can have a handful genital syndrome, which have different characteristics with the cleft hand and foot. You can have the TBX5 mutation disease, which is going to produce the Holt-Oram syndrome, and the Holt-Oram syndrome is also going to produce your cleft hand and cleft foot with the different other signs and symptoms. Now another disease is osteogenesis imperfecta. So when osteogenesis imperfecta is just a genetic disease, it is a genetic disease where you have an in utero lack of mineralization of bone. So it is far in utero. So it's a genetic disease of bones where you have in utero lack of mineralization of bone. So you have excessive osteoid formation. So it's just like a form of rickets, but rickets usually is more because of nutritional deficit of vitamin D. Is it clear? But when you have these patients, you can give them vitamin D, but they are coming in utero. You give birth to these children with this osteogenesis imperfecta. Is it clear? Vitamin D is not going to change anything when you give them, but it may only try to improve the lifestyle, the standard of living. So we have osteogenesis imperfecta is going to be characterized by shortening, bowing, a hypomineralization of long bones. All these are characteristics of rickets when you have lack of vitamin D. Is it clear? These are examples. This is brachydactyly, this is syndactyly, fused fingers, this is polydactyly, extra finger, and this is a cleft foot. Now you can visualize here, there are several types of osteogenesis imperfecta, ranging from persons with mildly increased frequency of fractures. to different types. Now the next one is Marfan syndrome. So Marfan syndrome, so that's why you need to know that osteogenesis imperfecta is type 1 collagen disease. Now Marfan syndrome is not really a collagen fiber disease, but you can still consider it as a collagen fiber disease. It is a mutation. When you have a mutation of the fibrillin gene, basically when you have mutation of fibrillin gene, the patients here are characterized with tall, slender, long, thin limbs and the faces. They have also other defects like sternal defect with pectus excavatum and carinatum. You have hyperflexible joint, you have dilation and or dissection of the outer, and then you have dislocation of the lens. Now the next disorder is going to be an arthrogryposis or congenital joint contraction. Arthrogryposis usually involve more than one joint and may be caused by neurologic defect. So when you have joint contracture, like in this case you have bowing of joint and all that, this is going to be a case of osteogenesis imperfecta. So when you have joint contracture, so it's going to be called arthrogryposis. Arthrogryposis, this infant has arthrogryposis because he has contracture of joints. Is it clear? So contracture of the joints at the level of the limbs is going to be called arthrogryposis. This one now, these are band disorders. So you have digit amputation. This is also another digit amputation because of an amniotic band disease. So amniotic band disease are also there. So these are the transverse limb deficiency, which may be caused by disruption of vascular or due to vascular abnormalities. So you see that here you have a limb amputation, a transverse limb deficiency. Now in transverse limb deficiency, these are limb defect in proximal structures. So in which proximal structures are intact, but the structure distal to a transverse plane are partially or completely absent. The defect may be due to the dissolution of AER or signaling of vascular abnormalities such as thrombosis or vasoconstriction. So you can just consider this transverse limb deficiency as just an acute limb ischemia in utero. So when you have absence of vascular supply distal, the proximal structure as normal, but there's an amputation of the distal limb, not because of an amniotic band, but because of vascular disease and because of AER disruption. Is it clear? So there's going to be a transverse limb deficiency. Now congenital hip dislocation is also another problem because you have underdevelopment of the acetabulum and underdevelopment of the head of the femur. So when you have now congenital hip dislocation, you can use the Barlow maneuver to test for congenital hip dislocation and also use the autonomy maneuver in order to replace a patient with congenital hip dislocation. Is it clear? So those are the different things to visualize here. So from here we are finished with the limb development and go to the next tutorial. That's where I can